Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by Village MD, primary care physicians, practice medicine the way you've always wanted, data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi, everyone. Welcome back to Working Smarter. Welcome to our annual sort of push out of various updates with physician fee schedules and just different coding changes that CMS is pushing out. This episode, we're going to be talking about the medical decision-making changes that we're expecting to see in 2021. Once again, we're joined by two of our Village MD experts, Erdest Jenkins. She's a coding educator that works for us. And then John Torontow, he's a national medical director, and he's a physician who works for Village MD. Thank you so much both for joining us, and excited to learn about these new changes. It's pretty major, right? So Erdest, just talk to us about what's coming and what physicians can expect to see.
So great lead in, Janessa. What has changed? We talked about previously that there's code levels that have been eliminated. So now we're going to talk about what's no longer required and what is required. So these changes are starting in January 2021. Major change is that history and exam elements are no longer components for code selection. But again, a medically appropriate history and or physical exam should still be performed. So in other words, we are still expecting to see a history and or physical exam in the documentation. It's just not going to be required as far as us counting your bullet points. So code selection will now be based on medical decision-making and or times for the new evaluation and management codes. So we're going to delve into exactly what medical decision-making is.
Yeah, so there's sort of three elements that CMS is concentrated on. So what are those three elements that we're seeing?
So the first element that we're looking at is problems. And problems are basically the concerns that you're addressing at the visit. And a key point in this is concerns that you're addressing at the visit. So CMS has long stated that when you're choosing an evaluation and management code, your documentation should address the issues that you are addressing at that visit. So basically, if a patient is coming in for management of their chronic conditions, hypertension, diabetes, COPD, and on the previous visit, they came in and they were having UTI issues. So you would no longer document that UTI issue if the patient is not having those symptoms. So we just ask physicians to be cognizant of the problems that you're addressing with the patients at that visit and that you're documenting those problems. The next element is data. Every unique test order or document that you reviewed for that visit, where we understand that physicians look at a variety of tests, a variety of information for the patient. There are occasions when that information is not accurately recorded. So we ask and we encourage each physician to document every test that is ordered and also document the results of those tests and any documentation regarding the results of those tests. We know that the providers are addressing those issues, but there are instances where it's not documented, which we go into the element that CMS says, not documented, not done. So we just encourage proper documentation for all of that data. And the last portion of it is the patient's risk odds of complications for morbidity and mortality. So basically you address what the risks are for the conditions that you are treating, what their morbidity or mortality is. And so again, we just ask that you document everything, because at the end of the day, documentation of the patient's condition goes towards continuity of care. It goes towards making sure that our patients receive the best care that's possible.
Great. And let's talk about, a little bit further of what physicians need to satisfy in order to meet these new NDM requirements, right? So part one, talking about number and complexity of problems. Erdest and Dr. T, do you want to walk us through what needs to be done and how physicians should be thinking about this?
Yeah, I'll take a shot and then Erdest can correct my mistakes. But when we're thinking about this, this is probably the most analogous to the previous way, right? It's the number of things you're actually managing. So you need to be explicit of what you're taking care of. So if you're doing something with evaluating hypertension, evaluating diabetes, evaluating COPD, evaluating CHF, we want to make sure that's clear from the note that you're actually doing something about it. The other thing about that, beyond just the number, is the complexity. And physicians tend to underestimate the complexity given they just get used to taking care of patients who are pretty complex. But if you've got a chronic problem that is uncontrolled, that sort of moves you into the more complex. So, and common things that are poorly controlled include hypertension and diabetes, and I would argue at times obesity and sometimes depression are also things that chronic diseases managed by primary care providers that are often uncontrolled and therefore more complex. So you want to be very explicit when you're dealing with this in terms of not only the number of problems that you're managing, and most primary care providers manage every one of their patients' problems. They just don't always put them on the chart. They manage them. So you want to be explicit about what you're managing and also the complexity. What do you think, Erdest?
And that is correct. In my years of auditing, I've come across physicians that are managing very complex patients. To them, the patients are routine, but in actuality, it is complex. It is complex to manage hypertension and diabetes and COPD in a patient that's 70 years old. So what I have found over the years is that the documentation is there, but what is actually being done for the patient or the complexity of the diagnosis itself is not being documented. A patient that has hypertension and that's always borderline of being over what the AMA would consider controlled, our physicians are not documenting that it's a chronic condition and that it's uncontrolled. They generally just document hypertension. So just again, making sure that the providers are documenting the complexity of the problems and how many problems they are actually addressing on each one of those visits.
Perfect point. So part 2, in mountain complexity of data to be reviewed, and you get credit for reviewing old records. That's old records externally. You don't get credit for in medical decision making for reviewing the chart, of flipping through all of the documents. Sources outside of the patient. So that could be an external professional that you need to talk to or had to talk to, or if you need to call someone, phone a friend and get some help, some sort of e-consult, or just to talk to a specialist that might have seen the patient. Again, that all counts. When it comes to ordering and reviewing tests, obviously there's imaging and tracing and tests and specimens. When you do order a test, think about panels counting as one. So a comprehensive metabolic panel is one test, for example. It's not showing my age here. How many tests are in that? Is that a Chem? I don't even know if it's a Chem 13. Anyway, it's terrible. But nonetheless, you can't get credit for individual tests. And then I think you also, again, medical decision-making also includes rationale and why you're ordering the test. You definitely want to support that. If you're ordering a head CT, why are you ordering a head CT? What else did I leave out?
You did great, Dr. T. And, often our physicians make note their patients went to an urgent care facility over the weekend, and so they're coming in to see us on Tuesday. And there are times when the patients will bring the information with them, the results of what happened when they went to the urgent care facility, but it's not documented. Providers will put patient went to urgent care on Saturday, and that's all. Well, if you're actually reviewing the chart notes from that urgent care facility, then again, that's reviewing information from an outside source. So just make sure that if the provider is actually reviewing an outside source, if they're actually reviewing a note from another provider, that it's documented, because it will go towards the rationale of why you might be ordering another test for, patient went for chest pains. And so now you want to order a nuclear test. And they went to the urgent care because of the chest pains. So just making sure that they document it so they can get credit for it, because the providers are spending time reviewing this information, and we want to make sure that they get credit for that information.
Yeah, excellent point. And then part 3 is risk. And this is to your point you made earlier about folks who are used to complexity. We tend to downplay the risk that we're seeing until it's clearly obvious. And the top level risk is that patient who needs a higher level of care. If you're calling 911 from your clinic, it's pretty obvious that's a risky patient. But a lot of the risk involves even treatment. So prescription medications, diagnostic procedures, some entail a higher risk than others. That's something else you want to think about. The bottom of this risk would be basically not even over-the-counter medication, like watchful waiting, supportive care as an example. But there's all the levels of risk, and it's important. And we've got a chart that will show you that you understand what these are when you're coming to management, so that you, again, document the work that you're doing and you get credit for the work that you're doing. What are your thoughts, Erdest, based on your experience here?
And you're absolutely correct. One of the deficiencies that we see is the comorbidities are not documented. The diagnostic procedures not documented. So again, it's just important to document everything that's done for the patient. And this does go towards, again, continuity of care, making sure that our patients receive the care that they need in order to manage their conditions.
Excellent.
Excellent. So we always think it's best to sort of give some real life examples as much as we can to put it sort of in context of what a physician may see in, their normal course of work and how these new rules would apply. So we have a little example on screen, and if you're watching along, you can follow it. Dr. T, can you walk us through what this patient is, how they presented, and how you would sort of document this?
Yeah, absolutely. And thanks. So this is, if you imagine Miss Smith's a 67-year-old female who's coming in for a 3-month follow-up for COPD. What's that? That's the Q90 visit, right? So we're seeing her every quarter, but she also has diabetes and hypertension, hyperlipidemia, as well as obesity. You'll notice this note is pretty short. And if you look closely, you might be surprised at what's not there. What you don't see is a long HPI that has a long review of systems. Now, I may have asked those questions. I may not have. If she's stable, it's pretty simple, pretty straightforward. If she's having an exacerbation, this note's going to change in how I document it. I might even have some physical findings. But in this case, her reason for coming in is COPD. She's doing well with that. So there's no long HPI with review systems, and you'll also see no physical exam. So I just did note here that she reports that she doesn't always take her metformin because her sugar doesn't always feel high, that she takes her blood pressure medication daily, but she also struggles to exercise and eat properly. So I'm setting the stage of how I'm going to list and manage these problems in this note. I'm throwing in some data here. Her last A1C was in June, and it was 8.1. We have a blood pressure measurement here, which would be a physical exam. It's a vital sign. The BMI is in the note here at 38. We could also put that here at this line. So he's got some element of, I've got some data, I've got some problems, and you'll also see my problems are going to be in the assessment here. So COPD, simply, there's really not much going on here in terms of her COPD. I make note of the data, and I'm congratulating her. That's super important, just clinically, but not too complicated. Her diabetes, on the other hand, she has hyperglycemia. So I want to make sure that that's clear that she has hyperglycemia as a complication of diabetes. And we're going to reinforce this idea of taking medications even when she doesn't have symptoms. There may be some health literacy that's interfering with that. We're going to encourage her to follow up, again, everything you would do. But I'm just being very explicit about what I'm talking about with the patient, because this is my medical decision-making. Hypertension, well controlled. We've got some labs coming up in the next 3 months, but we're not spending a lot of time on that. BMI, again, is unchanged. Really like to help her do a little bit better with weight loss. She's got some constraints, again, financial, so that social determinants of health are limiting her ability to do something like Weight Watchers. But we set a goal together that she's going to increase her walking to 30 minutes a day for 5 days per week. This is a pretty basic visit in my mind that most clinicians would do in this situation. It's pretty fast, pretty simple. And you might go, wow, what could this be? And that's sort of the exercise. So where did I land? And that's where I want Erdest to tell me, what does she think about my documentation for Miss Smith?
I'm going to attempt to code this chart really quick. So in looking at this, so the first thing that I am looking for, number and complexity of problems addressed at the encounter. So for this particular patient, we had 4 conditions the patient had. So she had her COPD, her hypertension, the obesity, and her diabetes. So when we were looking at the chart, she had 4 conditions. 1 was considered stable. You had 3 that were considered unstable. So at that point, the number and complexity of problems that were addressed at this particular encounter, we fell on the moderate level. And that was due to the treatment and the multiple chronic conditions and the number of conditions that were addressed during the visit. In this particular note, Dr. T did great about listing the conditions and what was going on with each of them. And as you can tell in the note, it doesn't take a lot of documentation to address each one of those issues. Moving on to part 2 with the amount and or complexity of data to be reviewed. So we looked at her previous A1C. We also looked at her blood pressure. So we also looked at her BMI. At that point, again, we have met a moderate level because we did an evaluation of them. Dr. T also looked at her CAT scoring and the goal grouping, which are measures that are associated with the COPD. In addition to both of those things, he also ordered a future A1C and a BMP, which is a basic metabolic panel. So he's documented that information. Again, we're at a moderate level. Didn't take much to document that information. The very last part, which is the most important part, was the risk of complications and or the morbidity in the patient management, again, was high. What Dr. T noted was what he was suggesting for the patient with her diabetes, make sure she takes her medicine every day. That seems to be one of the issues. And again, it has to do with the challenges. She is a 67-year-old patient. So at that point, we're looking at age, forgetting to take your medication. I forget to take my medication sometimes on a daily basis, and I'm not quite her age. So again, it's the medical management problem was considered moderate. So at this point, Dr. T hit the moderate level for all three. Also, what Dr. T stated on is at any given point, your documentation might not hit moderate. We're only looking to hit 2 out of the 3. So if we had on level 2, 2 things that we looked at, say her A1C, and we only ordered a BMP, we would be at a limited. But we looked at part 1, we had moderate. We looked at part 3, we had moderate. We would still be at an overall MDM of moderate.
Great. So let's talk a little bit about what the documentation requirements are going to really entail. So Erdest, if you can talk a little bit about, that sort of high level overview of these requirements.
So high level, the most important thing to remember is that the changes only affect office or other outpatient codes, which encompasses the evaluation and management services of 99202 through 99205, 99211 through 99215. The 99201 has been removed as it has the same requirements as a 99202. They don't apply to any other evaluation and management services such as hospital or emergency room. The next thing to know is the correct evaluation and management level selection along with MDM will drive accurate Medicare reimbursement for services rendered by the providers. So in other words, as long as your medical decision-making is there and the documentation supports the medical decision-making, the providers will be reimbursed accordingly. Also, make sure to use all problems directly addressed at the encounter for that particular date of service for your level of decision-making. In other words, problems that were addressed and resolved at a previous visit, you're not going to bring them over to the new visit. Last but not least, documentation and initiation of all changes in treatment. So anything that you have considered, reviewed, monitored, suspected, or discussed or ruled out, please make sure that it is documented. Because again, at the end of the day, CMS says not documented, not done. So we just encourage documentation at the date of service, preferably at the time of service, but we do understand that time constraints sometimes prevent providers from documenting at the time when the patient is there, but we do ask that it be done in a timely manner. Then that eliminates the forgetfulness that we sometimes encounter in our busy days.
Great. And then we'll make this chart available for your download after this session. There's a lot of information, so it's probably going to be best that you don't just memorize all of this unless you really want to memorize everything, but just have this sort of available by the side of your desk or hung up by, the computer where you do your documenting. And that way you can sort of reference these and figure out where you're hitting on the medical decision-making sort of scale. And I think we're trying to emphasize that you're supposed to be hitting 2 out of 3, right, Erdest?
That is correct, 2 out of the 3. But again, just make sure you document everything that is pertinent to your patient's care on that particular date of service.
I mean, I think you're definitely going to need this as a reference. You're probably not going to memorize it, but I think like other folks who, once you understand the way it works, it'll become pretty easy. But just understanding the moderate and the extensive and what's low, and there's good examples out there as well to, you'll know when you're dealing with something that's minimal, super straightforward. But most of your chronic disease management is going to fit somewhere between the 99213s and 99214s. And I think most of them are going to be 99214s based on the example. If you're managing 3-4 chronic diseases at a time, especially if one of them's unstable. And then the high risk, again, is going to be pretty obvious to you who those people are. They're going to not be so common. But again, I think it's going to be a great tool to have at your workstation so you can refer to it. But with time, I think this should work out pretty nicely. Again, I think one of the challenges that clinicians are going to face is to actually remind themselves of all the medical decision making that's actually happening between their ears that they're just not giving themselves credit for. I think that's going to be a challenge for many folks out there.
Yeah, that's a great point. If you work with VillageMD, we're happy to give you more, resources, and we have various staff members who will be able to help you walk you through this. We can provide additional resources if needed. And if you're not working with us, feel free to call us. But I think, these overall changes are great for primary care. They're going to be better for primary care physicians to get paid for things that they may have been doing and weren't getting paid for, and hopefully decrease documentation burdens overall. So thank you both so much for joining us, and we look forward to having you on more future episodes.
Thank you to our sponsor, VillageMD. We hope you will join us for future concise compliance conversations.